everyone, and welcome to our last recorded lecture of the semester. This, our final module, focuses on the universal topic of death and dying. Here are our objectives. We want to describe end-of-life care and what constitutes a good death. We want to define and explore the meaning of loss and how to support the bereaved, and we want to discuss end-of-life options. Now, death at its most basic is the ending of one's physical existence. It is obviously a universal experience, but one we actually know very little about. People are alive until their heart is unable to circulate blood and their lungs cannot send oxygen to the tissues. In recent decades, that doesn't necessarily mean the end. It is possible, for example, to shock a heart back into beating, often many times, or to support lung function by putting a tube down somebody's throat and having a machine breathe for them for very long periods of time. This raises whole issues in and of itself, including when is it right to stop providing this? For perspectives on death, it is important not to assume that any one person is or is not prepared to die. Our particular society is one where death remains a somewhat taboo subject, whereas people may not have formulated really what their thoughts and feelings are around it. Conversations about death and dying are uncommon and also shaped by our own experiences with death and our own perspectives. One thing that is true is that fear of death typically peaks when one is young, can create a lot of anxiety around it. As you get older, it becomes less abstract. And very often you'll hear people say, well, I'm not really afraid to die, but I am afraid of this or that or something else that happens during the process. Loss occurs when an event is perceived to be negative by the individuals involved and results in long-term changes in one's social situation, relationships, a way of viewing the world, and oneself. Death is the event most often thought of as a loss, but there are many others. And one kind of philosophical view around it is that loss is universal. We all have many of them that happen over the course of our lives. But it can help a person gain a better perspective and understanding of their life and eventually learn how to rediscover joy in a different form. Grief is a natural and normal response to loss. It's the emotional suffering you feel when something or someone you love and care about is taken away under whatever circumstances that may be. Your book gets into some types of grief that are considered not normal and even pathological, but I'm not going to really delve into that here. Suffice it to say that often the pain of loss can feel overwhelming, and people can experience all kinds of difficult and unexpected emotions, from shock to guilt to profound sadness. The pain of grief can also disrupt your physical health, making it difficult to sleep or even sometimes to think or read or concentrate. Again, these are normal reactions to loss, and the more significant the loss, in general, the more intense the grief can be. Grief differs from mourning. Grief is inward, whereas mourning is the outward expression of grief, like wearing black. This slide seems a bit busy to me because it basically lists every feeling there is as a grief reaction, but it is true that grief is complicated and expressed differently by each grieving person, and there is no one acceptable or perfect way to grieve. In fact, one barrier to people having a healthy grief experience is the perception of others that the way they are handling their grief is wrong or just somehow not normal, and feeling really judged by it. Your book goes through a few theories on grief. Probably the best known of these, one that's been around for a long time, is the stage process model that Elizabeth Kubler-Ross popularized uh, and has since updated. But it basically outlined 5 stages of grief that help dying people and those around them really come to terms with impending death. The first one is denial. Um, it's wrong. Something else is happening. I'm not going to die. Next one is the anger. Why did this happen? Why me? I'm not ready. Um, Third is bargaining. Uh, if I can just have a little more time, I'll make sure that this or that happens as a result. The depression that says, comes in that says, no matter what I do or how I feel, I'm going to die. There's nothing I can do about it. And um, becoming very sad around that. And there's acceptance. I'm going to die, and this is when you start saying your goodbyes, making your plans to no longer be here. Now, obviously, these are uh, stages that you can go through sometimes simultaneously, sometimes not necessarily in that order, and maybe sometimes not even everybody goes through them. But this is the best known theory that we have out there on how people manage their grief process when they are facing death. This is a list from your book about caring ways to interact with someone who has experienced a loss, as we all do. It is not helpful, for example, to say, it was for the best, he was really ill, they're in a better place. It's not helpful to simply avoid the topic, particularly when people are making overtures that they want to speak about it. It's not helpful to avoid topics that cause discomfort, to change the subject, because that's all about us. That's all about us and our comfort level in dealing with this subject. And it's not helpful. It's not other-centered. It's not centered around the person who has experienced the loss and how you can support them. Rituals are often utilized in coping with loss and grief and to help us with some societally recognized markers. Um, Funerals, for example, are the first step very often in ritualized behaviors after a loss. Everybody understands that a funeral happens after a person has died to recognize the life of that person and to try and move on from that person being physically there. It helps to strengthen feelings of social connectedness. People can offer support at that time, and it does help to provide meaning around that loss. Excuse me. Good death is kind of a term without a lot of meaning per se. It does mean something different for everybody. Everybody has an idea of how, we all know we're going to die. We all do think about it, and we all do have some idea of how we would like that to go. Most of us, if you asked us, would say that we want our death to be pain-free. We do not want to have suffering at the end of our lives, and we do not want to impose ourselves as a burden on our loved ones. We want our life to be aligned with our own wishes, our family's wishes, and consistent with cultural and ethical standards. A lot of people will say, for example, I don't want to die in the hospital. I want to die at home, surrounded by the people I love. And whether or not that is or is not possible, that's what a lot of people will express. Now, your book talks under the Seeking a Good Death, your books list suicide. We've had a conversation about suicide earlier in the class. I do want to mention it here because even though it can't be considered a good death from a healthcare or cultural standpoint, people who do opt to take their own lives are very often thinking that it is the best way forward. It is illegal in most states. Many cultures view it as morally reprehensible. that you will be denied entrance to heaven, for example, if you take your own life. And for the elder population, there are very high rates of suicide, particularly in elderly men. And again, there's a limited number of programs developed for older adults to address suicide. So while you can't think of it as a good death per se, from the person's perspective of who's going through it, it may seem to be the only way out. Euthanasia, again, we think of it more in terms of our pets, but it is the act of killing another being. There is what's called passive euthanasia, which is standing by and not taking action to prevent death. That does happen often in cases of terminal illness where, for example, artificial feeding is stopped or breathing or infections aren't treated, those types of things, because the idea behind it would be that you're simply prolonging the dying process. And then there's active euthanasia, which is taking the direct action to shorten life. By and large, it's illegal unless we are executing a criminal. For physician-assisted suicide, that's the taking of one's own life under the guidance of a physician. Now, in 2019, Maine established the Maine Death with Dignity law, which allows terminally ill adults who meet certain qualifications and who have been determined by the person's attending physician to be suffering from a terminal illness as defined in the Act to make a request for medication prescribed for the purposes of ending a person's life. Excuse me. The law establishes the procedures for making these requests, including 2 waiting periods and 1 written and 2 oral requests, and requires a second opinion by a consulting physician. The law also requires specified information to be documented in the person's medical record, including all oral and written requests for medications to hasten death. Planning for end of life generally involves making out an advance directive. Advance directives are legal documents that allow one to spell out your decisions about end-of-life care ahead of time. They give people a way to express their wishes to family, friends, and their healthcare providers, and to avoid confusion later on when you are sicker and quite possibly not in a state to make those decisions for yourself. A living will tells which treatments you want if you are dying or permanently unconscious. Very often people are like, if there is no chance of recovery, please remove me from the ventilator, please stop the artificial feeding, and you can accept or refuse medical care. You might also want to include instructions on things like the use of dialysis for kidney failure, for example. What do you want to have your organs or tissues donated? Those types of things. A durable power of attorney for health care is a document that names your healthcare power of attorney, also called a proxy, which is someone the person trusts to make health decisions in that person's interests if that person is unable to do so. I, for example, am my mother's healthcare proxy if she becomes unable to make those decisions for herself. However, up until the moment she is not able to do that, she has the right to make all those decisions. And again, these are not permanent. They can be changed. They can be altered by the patient at any time. A do not resuscitate order or DNR order is a medical order that's written by a doctor that instructs healthcare providers when essentially not to do cardiopulmonary resuscitation if a patient's breathing or heart stops. If someone has a DN order, they, again, like with a living will, they do have the right to change their mind and request CPR. But basically a DNR order states, if something happens to me, and a lot of times people who've got advanced illnesses, bad heart disease, cancers, these types of things, will say, if you find me and my heart has stopped, please do not initiate resuscitative efforts. And again, that does have to be a physician's order. As far as organ donation goes, while it's not common amongst the older adult population, it's important to know that there is no age limit for donation or to sign up to donate one's organs. In 2021, for example, 1 out of every 3 people who donated organs was over the age of 50. You're never, excuse me, and the oldest organ donor in the United States was 92. There are obviously things that make it more complicated in older adults, things like heart disease, macular degeneration, a lot of stuff that would make it inappropriate for somebody or not useful for somebody to donate an organ. But age in and of itself is not, doesn't rule one out. Now, hospice care for end-of-life options, hospice care at its most basic is a type of health care that focuses on the palliation of a terminally ill person's pain and symptoms and attending to their emotional and spiritual needs at the end of life. It's actually an insurance option for Medicare and many other non-Medicare insurances, and as such has a lot of criteria about who can access it. The bottom line for admission to a hospice program is that 2 physicians certify that the patient likely has less than 6 months to live, although if a person lives longer, they don't get kicked off the program. In southern Maine, there are a couple of big providers of hospice services. The first is Hospice of Southern Maine. It's out of Scarborough. I put a link to their site here, as well as Northern Light Hospice, in which I have a link to that as well. And here's just a list of the differences between hospice care philosophy and medical care. Hospice care really is focused on palliation of symptoms and of taking care of the family unit while somebody is undergoing the dying process. One thing hospice care does offer as well is bereavement care for the family members and friends for up to 1 year. And finally, there is the care of the dying person themselves. Now, this is an aspect of death and dying that your book kind of glosses over, but it is as important, if not more so, as any of the rest of the information that's been presented thus far. People who are dying are still people with all their failures and foibles, as they always were. And it has not been my experience over many years that the dying process makes anyone nicer or more serene. It's like any other stressful event. It can make people irritable and difficult to deal with, even for their closest family and friends. It's also stressful for us as professionals because every time it happens, it brings up our own fears and feelings about our own mortality. We're all going to die after all, and the older we get, the less abstract this becomes. So we as professionals need to be available to talk with people openly about dying, about their feelings, about their hopes and wishes for the process, just as we need to be with other uncomfortable topics like sex and suicide that we talked about earlier. This is a very simplified list, but it does touch on some important aspects of caring for someone who doesn't have long to live and probably knows it. More than anything, be willing to listen and ask questions. One of the best things I think was said in the Being Mortal documentary was when the provider noted that people have goals that are more than simply extending their lives. And finding out what those are and how we can help make them happen for somebody is, in my opinion, one of the most important care aspects we can offer. Okay, that is the end of this module, and thank you for your attention.